Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is the last in the series of infertility, and it is assisted reproductive technologies. We have already seen tubal factor of infertility, male factor of infertility, ovarian factor of infertility, along with the management, initial assessment in a case of infertility, and this is last in the series of infertility, which mainly deals with the assisted reproductive technology, as it is the most expanding science and ever changing science related to this topic of infertility. Now, I want to mention here that this video is not for IVF specialists, but it is mainly for the students and consultants of obstetrics and gynecology who are actually not actively involved in these techniques of assisted reproductive technologies, but they should have the idea about the various techniques, or what is the technology which is being used at present, and what are the newer advances which are happening in this field. And that is why this video is mainly meant for these postgraduate students, specialty students, subspecialty students of obstetrics and gynecology, and consultants who are not doing practicing ART, but who are dealing with infertility cases. Definition of assisted reproductive technology is any technique involving manipulation of oocytes outside the body. So it is this definition is relevant in the sense that whenever we manipulate the oocyte, then only it is assisted reproductive technology. For example, if we take IUI, intrauterine insemination, here we are not doing any manipulation to the oocyte, and that is why it is not coming under the umbrella of assisted reproductive technology. In vitro fertilization, IVF is the first and most common form of ART, whereas ICSI, that is intracytoplasmic sperm injection, was introduced a few years later, and that is also included under ART. All the techniques where the sperm isolation is done either from ejaculate or MESA, that is micro epididymal sperm aspiration, or TSE, that is testicular sperm extraction, all these also form the component of ART, in the sense that so many times sperm retrieval is to be the technique for the retrieval is to be employed while doing the assisted reproductive technology. It also includes donor sperm, donor oocyte, or gestational surrogacy. Pre-implantation genetic testing is also component of ART, PGT, and fertility preservation, especially medically indicated, such as patient is having malignancy, or electively patient wants to go for proceed with the choice of pregnancy a little later in life. These are the situations where uh, ART plays a role. In short, it is a topic of short forms. As you can see, ART, IVF, ICSI, TSE, MESA, PGT, all these are very commonly used whenever we are discussing this topic of assisted reproductive technology. Now, these certain other forms of assisted reproductive technology have already have been tried over the years, but these have limited scope in the present day ART, as IVF has almost completely replaced these other techniques because they do need laparoscopy and these are more invasive. The techniques which were tried were gamete intrafallopian transfer, zygote intrafallopian transfer, where a single cell fertilized ovum was transferred into the fallopian tube, and tubal embryo transfer. All these are less commonly used techniques now, and mostly whenever we say ART, it is almost always now synonymous with IVF, in vitro fertilization. Indications for IVF are severe tubal disease, severe male factor infertility, multi-factor infertility, failure of other treatments of infertility, unexplained infertility. So these are easier to remember also. that whenever there is a tubal disease, it is obvious that what is the severe tubal disease, then the choice is IVF. Severe male factor infertility is also forms one of the major chunk of the case patients who are going for IVF. Multi-factor infertility, failure of all the treatment options, and unexplained infertility. Apart from these, there are three groups where IVF is required because of the some additional reason, such as patients who need donor oocyte, women having premature ovarian failure or after menopause, those who need surrogacy, such as Mullerian agenesis, severe intrauterine adhesions, post hysterectomy, and there is some medical disease which is contraindicating pregnancy. Those who need pre-implantation genetic testing, such as one or both the partners are affected with either autosomal or sex-linked diseases, or there is a balanced translocation in one of the partner. So to remember, you remember like that only, because these five are easier to remember. But then group them in under these three categories as those who are needing, those who are in need of donor oocyte, those who need surrogacy, and those where there is a pre-implantation genetic testing is indicated. What do you mean by unexplained infertility? Is diagnostic criteria or definition? It should have minimum. Normal semen analysis should be there. Normal ovulatory function should be there. Uterine cavity should be normal, and at least one patent tube to be there. If all these four criteria are getting fulfilled, then we can label it as a case of unexplained infertility. Now, IVF is indicated whenever there is a tube in cases where there is a severe tubal factor infertility, severe male factor infertility, or certain cases of endometriosis, severe cases of endometriosis. And for these place of IVF for these conditions, it is requested that the viewer should visit videos on these uh, topics at PGOG so that it will become uh, clear in which case of endometriosis IVF is indicated. In which situation where there is a male factor infertility, we proceed with decision to proceed with IVF. What are the cases with tubal factor infertility where IVF is necessary? For the clarity, it is requested that the viewer should visit these videos. Coming to prognostic factors for the success of IVF, the most important is maternal age. Younger the patient, better is the success rate. Ovarian reserve is the next, and for that also again request to the viewers is to go through the video on ovarian reserve so that we understand the place of this test for ovarian reserve related to our decision making and counseling of the related to the IVF. Then cause of infertility also is one of the prognostic factor. That means what is the diagnosis? Why the decision for IVF is being taken, and previous obstetric history. Before IVF, we need to evaluate the patient by doing ovarian reserve tests such as FSH, AMH, and AFC. These tests help in pre-procedure counseling about the risk of IVF failure, which is very, very important. Low reserve is not a contraindication for IVF is the most important concept. Though the failure rate might be higher, it is not a contraindication to proceed with IVF even if a woman has a low ovarian reserve. Semen analysis mainly to decide whether to proceed with conventional fertilization or whether there is a need for intracytoplasmic sperm injection. Infectious disease screening for both the partners for HIV, hepatitis B and C, and syphilis is necessary, especially for the protection of the staff working at the IVF center, as well as for the possibility of transfer of infection to the offspring. Imaging of uterine cavity mainly to see the for the whether the IVF will be successful, and there should not be any pathology which might reduce the pregnancy rate. For that, sonohysterography or HSG to be done to rule out submucous myoma, endometrial polyp, or presence of even a connecting large hydrosalpinx. Now, these are the steps of IVF. It is important to remember these steps. And the first three steps, as we can see here, are related to oocyte. Then fourth step is related to sperm. Once we get the oocyte and the sperm ready, then is the first stage of fertilization. After fertilization on embryo itself, we are having another three procedures to be carried out, and then only embryo is ready for embryo transfer. So first is oocyte stimulation. After the stimulation, next is oocyte retrieval. After we retrieve the oocyte, there is a step for oocyte maturation, sperm retrieval to get the prepare the sperm. Then either by conventional fertilization technique or ICSI, fertilization takes place. Once the fertilized ovum is there, then embryo culture. After that, assisted hatching. We will see what is the meaning of all these terminologies, hatching. Then pre-implantation genetic testing, and then this embryo is ready for embryo transfer. So these are the 9 steps, and one by one we will quickly go through all these steps of the IVF. Ultimate goal of ART is to have a singleton pregnancy delivered at term where the mother and the baby both are healthy. There are three components of IVF ovarian stimulation. First is use of gonadotropin for multifollicular development. Second is use of GnRH analog. Analog includes agonist or antagonist. Analog is the umbrella term, and whenever we say GnRH analog, it can be either agonist or antagonist. So we need to specifically mention whether we are using agonist or antagonist in these ovarian hyperstimulation protocols of IVF. So these are used to suppress the HPO axis to prevent spontaneous ovulation before oocyte retrieval. Now here, third component of stimulation regime is SCG, which is used as a LH for final stage of oocyte maturation. Now our aim of SCG here in IVF program is not to have the ovulation, but as a trigger for ovulation, but it is a trigger for final stage of oocyte maturation. Various regimes which are used are natural cycle, which is less commonly used, which where there is no stimulation, and it is less commonly used because of the associated less success rate. Minimal stimulation with clomiphene citrate. Clomiphene citrate along with low dose gonadotropin as called as a mild stimulation wherever patient cannot afford the uh, expensive drugs such as gonadotropins and GnRH analogs. And aggressive protocol or stimulation is where we are using gonadotropin with or without GnRH analogs. With natural cycle, the advantages are there is no ovarian hyperstimulation syndrome or multiple pregnancy, risk is not increased, cost is less, but success rate is only 7%, and that is why it is not in use whenever we want to proceed with IVF. Clomiphene citrate 100 milligram daily from day 3 for 5 days along with SCG leads to less or low egg yields. That means oocyte retrieval, the number is less. It is less effective than gonadotropins. Sequential treatment is where patient cannot afford gonadotropin along with GnRH analog. Then what is used is we can give CC, clomiphene citrate, and then we can initiate gonadotropin with a dose of 150 to 225 international units daily, and then we can use SCG as a ovulation trigger. This is low cost regime, but it is less effective as compared to use of gonadotropin along with GnRH analogs. Now we start with the commonly used ovulation stimulation regimes under the IVF program, and the first is called as long protocol, where we are using GnRH agonist down regulation and gonadotropin stimulation. As the name suggests, GnRH agonist is doing a down regulation. That means it is suppressing the hypothalamo pituitary ovarian axis. Whenever we give GnRH agonist, HPO axis down regulation takes place. That means suppression occurs. That reduces the endogenous gonadotropin secretion by pituitary. FSH and LH are not secreted by the pituitary because of the action of this GnRH agonist, and that is the main advantage of using this GnRH agonist for a ovarian hyperstimulation. Then when we use exogenous gonadotropin, that will lead to proper action on the ovary with multiple follicles developing in the ovary, but no premature LH surge and no ovulation before we proceed with oocyte retrieval. Advantages of this long-acting GnRH against agonist use along with the gonadotropins is it prevents premature LH surge by suppressing endogenous gonadotropin. We have already seen it here. Stimulation can continue until follicles are larger and mature, so it leads to higher egg yields and higher pregnancy rates than gonadotropin alone stimulation. So if we use only gonadotropin, what it leads to is less number of uh, oocytes can be retrieved, because there is a risk of having a premature LH surge because of endogenous gonadotropin, and that is the reason we have to take a decision for oocyte retrieval earlier. So number of oocytes which are retrieved are less. Pregnancy rate is also less if only gonadotropin is used. So the addition of GnRH agonist drastically improves the outcome by with a greater egg yield or oocyte retrieval. Number of oocytes being retrieved is more, and it leads to increase in pregnancy rate also. Disadvantages of using this long-acting GnRH are the higher dose is required for the of the gonadotropins, and prolonged use of gonadotropins is needed, because as we have already seen, GnRH agonist is leading to HPO axis down regulation, so that the hypothalamus, pituitary, and ovary, all these are less sensitive to the exogenous gonadotropin. Ovary will be less sensitive to exogenous gonadotropin. So the uh, dose which is required, gonadotropin dose which needs to be used, is higher whenever we are using GnRH agonist, and it needs to be used for a longer duration also, which whenever we are using it for a longer time, that adds to the cost, as well as the use of GnRH agonist itself also adds to the cost. So overall it is an expensive regime. This is called as the long protocol, but this is considered as standard regime. It is the one which is most commonly used by the IVF centers all over the world. So what is this long protocol is? GnRH agonist is started on day 21 of the cycle. That means in the mid-luteal phase or 1 week after ovulation, this GnRH agonist is initiated. It is initiated at that time when FSH and LH nadir is present, so that there is no flare effect. Whenever we give GnRH agonist, initially for 2 to 3 days, there can be increase in FSH and LH, which is called as a flare effect. This will not occur because the endogenous or in the body FSH and LH are at the lowest level. There is a nadir here on day 21 of the cycle. Dose of GnRH agonist is 1 milligram per day, and this dose is continued every day. GnRH agonist injection is given till onset of menstruation. Once the menstruation starts, then the dose is reduced to 0.5 milligram per day, and it is continued till SCG trigger. GnRH agonist which is commonly used is leuprolide, or other GnRH agonists which are also tried are buserelin and triptorelin. Gonadotropin is initiated when estradiol level is less than 30 to 40 picogram per ml. That means there is down regulation by GnRH agonist, and we have to ensure that the HPO axis is sufficiently suppressed. So how we know that HPO axis is sufficiently suppressed is by doing serum estradiol level. When serum estradiol is less than 30 to 40 picogram per ml, and there are no follicles in the ovary greater than 10 millimeters in size, this is the time when gonadotropin is initiated. That means whenever GnRH agonist is given, every 2 to 3 days we have to do serum estradiol level, and we have to keep on doing ultrasonography mainly to see for these two parameters. When these two criteria are fulfilled, then gonadotropin is initiated. When there is a low estradiol level and when the follicle size is less than 10 millimeter. Dose of gonadotropin which is used is usually 150 to 300 international units per day of either urinary FSH, recombinant FSH, or HMG, human menopausal gonadotropin. Monitoring is done by estradiol and TVS, transvaginal sonography, every 1 to 3 days. Then SCG trigger is given with a dose of 5,000 to 10,000 international units when at least two follicles are present in the ovary which are of the size of 17 to 18 millimeter, and other follicles are of the size of 14 to 16 millimeters. And when estradiol level is in the range of in between 1000 to 4000 picogram per ml. Now this much students I think should remember that to initiate gonadotropin, estradiol should be less than 30 to 40 picogram. But to give SCG, it has to be 1000 to 4000 picogram per ml. No follicle greater than 10 ml when we initiate gonadotropin, and when we give SCG trigger, then we need at least two follicles 70 to 18 millimeter in size, and other follicles should also be sufficiently enlarged with a 14 to 16 diameter. Yeah, so this is diagrammatically again to repeat that we start this GnRH agonist on day 21 when endogenous gonadotropin levels are lowest. This is showing the lowest endogenous gonadotropin level. And here we are initiating GnRH agonist. We are giving 1 milligram per day. Like that we are giving every day. This is continued till the day of menstruation. Then the dose is reduced to 0.5 milligram per day, and it is continued till HCG trigger. Now, whenever we see serially we keep on doing serum estradiol level, and transvaginal sonography is repeated. And when estradiol level falls to less than 30 to 40 picogram per ml, or follicle size is less than 10 millimeters, then we initiate gonadotropin with a dose of 150 to 300 international units per day. Now, blue is for GnRH agonist, green is for gonadotropin. For all the rest of the regimes also, we will be using the same color coding. That is why I want students to remember that blue is for GnRH agonist, green is for gonadotropin, and this purple is for SCG. Now, when we give HCG trigger, estradiol is between 1000 to 4000 picogram per ml, at least two follicles of 70 to 18 millimeter in size, the rest of the follicles also 14 to 16 ml, and endometrial thickness is 8 to 9 millimeters, and it is a trilaminar endometrium. When all these three criteria are getting fulfilled, then SCG trigger is given with a dose of 5000 to 10,000 international unit. This is called as a long protocol because the duration of the GnRH agonist administration is quite long. Duration of gonadotropin administration also is quite long in this regime. Now, GnRH agonist action on HPO axis is, as we have already seen in the previous slide, there is an initial flare effect for few days, 3 to 5 days. So what is happening here is hypothalamus normally is releasing GnRH in a pulsatile fashion, and that leads to the release of FSH and LH by pituitary, Now, pulsatile means the GnRH is increasing and then it falls. Again, it increases, then it falls. When it falls, the receptors get the time to be recharged and ready for the next action of the GnRH. That is the advantage of having this pulsatile release of GnRH in a normal cycle. But whenever we give GnRH agonist, it is in a non-pulsatile fashion, continuous fashion, that leads to the receptor exhaustion at the level of pituitary. This is most important mechanism of action. I want all of you to understand that how GnRH agonist leads to down regulation is by this continuous non-pulsatile administration, which leads to receptor exhaustion, and that is why there is a reduction in FSH at LH. That is how it leads to HPO axis suppression. But initially it leads to flare. On the other hand, for initial 3 to 4 days, 3 to 5 days, there is an increase in FSH and LH, which is called as the flare effect of this GnRH agonist. So, flare effect leads to rise in FSH and LH. Continued use leads to exhaustion of pituitary receptors, HPO axis suppression, and fall in endogenous FSH and LH. This is the most important concept. I want all of you to remember how GnRH agonist action has initial flare effect and then there is a down regulation of HPO axis. Dependent on this flare effect, we have the next protocol, which is called as flare protocol or short protocol. Here, GnRH agonist gonadotropin stimulation is done. That means GnRH agonist is being used in this also along with gonadotropin, but it is a short protocol. What is standard short or standard flare protocol is shorter duration of GnRH agonist is given. Now, previous long protocol, we have seen that the GnRH agonist was initiated on day 21 of the cycle before menstruation, previous cycle. But here, what is done is GnRH agonist is started on day 2 of the menstrual cycle and continued for 3 days. So, from day 2 to day 4, every day GnRH agonist is given with a dose of 1 milligram per day. And after that, after 3 days, the dose is changed to 0.5 milligram per day. So, the initiation of the GnRH agonist is post-menstrual here. And this is continued 0.5 milligram per day till HCG trigger is given. Now, gonadotropin here is initiated from day 3 of the menstrual cycle. It is not that we see the serum estradiol, we see the size of follicle, and then only we initiate gonadotropin in long protocol. But here, this GnRH analog is initiated on day 2. Gonadotropin administration is initiated on day 3 of the menstrual cycle. Monitoring, rest of the monitoring is same as long protocol. Advantages are most important is less number of injections required. See, the blue is also short, green is also short. GnRH analog agonist administration is for lesser number of days, as well as gonadotropin administration also is for a lesser number of days as compared to long protocol. And so overall cost is also less. It is less expensive as compared to long protocol. Disadvantage is there can be increase in progesterone and androgen level because of corpus luteal rescue by this flare effect of the GnRH analog. As I said, flare effect, there will be increase in FSH and LH, which will lead to, now normally we know that what happens to corpus luteum is it passes through the stage of maturation, vascularization, and then there is a corpus luteum gets converted to corpus albicans. There is atrophy. But here there is a rescue of this corpus luteum as it occurs in a normal pregnancy. Similarly, here there is a flare of FSH and LH, flare effect of GnRH agonist, and that this persistent action of the corpus luteum is responsible for increased progesterone level, increased androgen level, and that is the reason there is a reduction in the pregnancy rate with this short or flare protocol as compared to the long protocol. That is why we say long protocol is considered as a standard protocol. I hope students have understood the difference between this short protocol or flare protocol and long protocol. Now, to overcome this problem of corpus luteum rescue, the third protocol which is used is called as use of oral contraceptive pills along with microdose GnRH agonist flare protocol. So what is done here is modification of standard short protocol to prevent corpus luteal rescue. What is done is OC pills are given for 14 to 21 days after the menstruation. 3 days after the last pill, microdose this GnRH agonist, that is leuprolide, is given. Leuprolide with a dose of 40 microgram per 2 times a day. That means every day 80 microgram. Now, initially in the long protocol or in the short or standard short protocol, we had seen that the initial dose of this GnRH agonist is 1 milligram, which is equal to 1000 microgram. You can imagine how much is the reduction here in the dose. That is why this is called as microdose, the microdose GnRH agonist protocol. Here we are only giving 40 microgram 2 times a day, whereas in all the other rest of the protocols, we are using 1000 microgram. Now this is given 2 times a day. That is why these two blue lines I have shown, that we are giving 40 microgram. As a microdose GnRH agonist is started 3 days after the last tablet of OC pill. 3 days after initiation of this GnRH agonist, gonadotropin is initiated. And both are given in the same manner for the rest of the criteria to be fulfilled, that largest follicles, at least 2 follicles, 16 to 18 millimeters, and estradiol in the range of 1000 to 4000 picogram per ml when the SCG trigger is given. Here, the corpus luteum formation is prevented by use of OC pills, and that is why this rescue does not occur, and that is why there is no rise in progesterone or androgen, and that is the reason why the pregnancy rate is comparable to long protocol, though the overall cost is less. Here we are using it for a shorter duration drugs and with a lower dose also. Now we come to the fourth protocol, where we are using, instead of GnRH agonist, we are using GnRH antagonist along with gonadotropin. So it is called a GnRH antagonist gonadotropin stimulation protocol. Advantage of using antagonist over the agonist is there is no flare action. It leads to GnRH antagonist leads to immediate HPO suppression. Shorter duration of treatment is required. No estrogen deficiency symptoms are seen. Less dose and duration of gonadotropin treatment is needed. Better results in poor responders. There is no flare effect, no follicular cyst formation. As sometimes with agonists, there is follicular cyst formation, which sometimes leads to difficulty even in oocyte retrieval. There is reduced risk of OHSS. GnRH agonist can be used instead of SCG as a final for the final stage of oocyte maturation. And that is the advantage of this antagonist protocol, that instead of SCG we can use GnRH agonist, because SCG use is associated with increased risk of OHSS. This antagonist protocol is a preferred protocol because of its ease of administration and comparable pregnancy rate, and it is especially more effective in poor responders. Now, disadvantage of using this GnRH antagonist is strict compliance is needed for dosing. GnRH and cetrorelix are the preparations which are available. Given as a 0.25 milligrams subcutaneously daily, initiated 5 to 6 days after gonadotropin initiation or when the lead follicle is 14 millimeter in size. Or even we can give cetrorelix as a bolus 3 milligram on day 6 of gonadotropin administration. So here gonadotropin is initiated on day 3 of the menstrual cycle. To reduce the endogenous FSH, we can use OC pills or we can give estradiol before initiation of this gonadotropin. Once we initiate gonadotropin after 6 to 7 days, GnRH antagonist is 5 to 6 days, GnRH antagonist is given. Now, here either we can give SCG or we can use GnRH agonist for oocyte or final stage of oocyte maturation. Now this GnRH agonist is preferred over SCG. SCG is associated with increased risk of OHSS, and to prevent ovarian hyperstimulation syndrome, GnRH agonist is given, and it can be given whenever we are using this antagonist protocol. So with a high risk for OHSS, such as for example PCOS, this GnRH agonist is preferred over HCG. And whenever fertility preservation, for that we are doing this ovarian stimulation. For that also this GnRH agonist use is preferred over HCG. So this is the advantage of this. Another advantage of this GnRH antagonist protocol, that GnRH agonist can be used for the final stage of oocyte maturation instead of HCG, ultimately reducing the risk of OHSS. Last is unconventional protocol, where random start stimulation protocol. It is also called as random start. Stimulation is started in luteal phase here. It is based on the fact that antral follicle recruitment happens in multiple waves throughout the cycle. It is not that antral follicle recruitment only occurs at the start of follicular phase. Another wave also occurs in the luteal phase, and based on this scientific fact, this protocol is used. It is useful in cryopreservation and in poor responders also. What is done is usual GnRH antagonist stimulation is done in the follicular phase, followed by GnRH agonist trigger for the final maturation of oocyte, and oocyte retrieval is done whatever number of oocytes which are available. Then it is followed in the same cycle by luteal phase stimulation. This is done that is why it is called as unconventional or random start stimulation protocol. Now, if we see the patient's response to ovarian stimulation in IVF, we can divide the patients in three groups as normal responders, poor responders, and high responders. Normal responders, selection of the protocol is as per the choice of the treating doctor or the patient, or depending on the patient's affordability or the drug availability or the experience of the practitioner who is IVF specialist. Based on these facts, we can go for a selection of a protocol in normal responders. In poor responders, it leads to cycle cancellation because there is no development of follicles, and oocyte retrieval is also not possible. So cycle cancellation is necessary. In these cases, we can try GnRH antagonist protocol or unconventional protocol. Whenever this GnRH agonist protocol fails, these are the cases of poor responders, then GnRH antagonist protocol or unconventional protocol might lead to a successful IVF. High responders are the women where there is a, after this protocol, development of large ovaries with large multiple follicles, serum estradiol greater than 5000 picogram per ml. These are the cases at high risk for ovarian hyperstimulation syndrome, and as you know, ovarian hyperstimulation syndrome can be a life-threatening complication also. So how we want to, now these are the cases where there is a risk of OHSS, and we need to take steps to prevent OHSS to develop in this situation. So the various options which are used are either cycle cancellation can be done or coasting can be done. What do you mean by coasting is stop gonadotropin for 1 to 3 days. Give a gap to gonadotropin administration for 1 to 3 days, but continue GnRH analog. Or in GnRH antagonist cycle, using GnRH agonist for instead of SCG, or we can add small dose of SCG to GnRH agonist for final stage of oocyte maturation. Freezing of all embryos. No fresh embryo transfer in the same cycle also will prevent OHSS. OHSS. Delay embryo transfer by 5 days, or use GnRH antagonist for few days. GnRH antagonist has immediate action, suppressive action on HPA axis, and it might prevent development of ovarian hyperstimulation syndrome. So these are the steps, various options which can be used by the treating doctor whenever there is a high risk for ovarian hyperstimulation syndrome in women who are called as high responders. Now, this is in short summary of ovarian stimulation. Ovarian stimulation or hyperstimulation forms the most important component of IVF on which the success of IVF is dependent. Aim of now these are the two separate terminologies. Whenever we say induction of ovulation, our aim is development of single follicle, which is the treatment for anovulatory infertility. But this ovarian stimulation for IVF is where the aim is development of multiple follicles. So multifollicular development is the aim of ovarian stimulation in IVF, whereas unifollicular development is the aim of ovulation induction for anovulatory infertility. Now, protocol. This is the long protocol where we are using GnRH agonist from day 21 in a higher dose, 1 milligram, then 0.5 milligram, and then we initiate gonadotropin. That is also required for a very long time, and then we go for SCG for final ovarian oocyte maturation. Second is short or flare protocol, where this GnRH agonist is started from day 2, gonadotropin is started from day 3. Here there is a risk of corpus luteal rescue and raise progesterone and androgen levels, reducing the pregnancy rate. So to prevent that, we are adding OC pills to this third protocol, that is use of OC with microdose of GnRH agonist, where we are using a small dose of leuprolide with a dose of 40 microgram twice a day. Then fourth protocol is antagonist protocol, where we are starting gonadotropin on day 3, and then after 6 to 7 days of gonadotropin we are starting this GnRH antagonist. Here as a final maturation, for that we are using either SCG, or in women having high risk for OHSS, we prefer GnRH agonist to be used instead of SCG. To prevent the existing FSH level in the body, we can reduce that level or suppress the endogenous gonadotropins. We can use either OC pills or estradiol along with this antagonist use. And last is unconventional, where for follicular phase we are using antagonist protocol and do the oocyte retrieval, and then do the same protocol in luteal phase also. Now, after ovarian stimulation, we come to the next step, that is oocyte retrieval and oocyte maturation. Retrieval is done 34 to 36 hours after this SCG trigger or GnRH agonist trigger. It is done under IV sedation, fentanyl or midazolam is used. USG guided transvaginal aspiration is done. Follicles up to 10 millimeters are aspirated. Throughout the procedure, continuous monitoring is done and prophylactic antibiotics are used to prevent introduction of infection because of this procedure. Rare complications are development of pelvic hematoma or tubo-ovarian abscess. Oocyte maturation is when there is a extrusion of first polar body, and when there is the oocyte is in resting phase of meiosis 2. That indicates that mature oocyte is present. 20 to 30% of the retrieved oocytes can be immature, and they need for another 48 hours to be kept in the medium for the development of this extrusion of host polar body and to become mature. Once the oocyte is mature, then we proceed with fertilization. Two methods are there. One is conventional microinsemination and other is intracytoplasmic sperm injection. The most important concept is results of conventional fertilization are better than ICSI in unindicated cases. So specific cases only this intracytoplasmic sperm injection is indicated, such as severe male factor infertility, where there is a oligospermia less than 5 million sperms per ml, asthenospermia less than 5% progressive motility, and teratospermia where there are less than 4% of the normal forms by strict formula to assess the forms of the sperms or abnormal forms, and to differentiate between normal and abnormal forms there is a criteria which is called as a strict criteria. Another indication for ICSI is failure whenever there is a failure of conventional fertilization or whenever surgically retrieved sperms are being used, such as by the testicular sperm extraction. As the sperm number will be less, it is better to proceed with ICSI in these cases. And whenever there is a need of PGT, pre-implantation genetic testing, then ICSI is preferred, as extra sperm attached to the zona pellucida can affect PCR. Now it is requested again to visit management of male infertility for various sperm retrieval techniques which is available on PGOG. In the conventional method of fertilization, semen sample is obtained. Sperm preparation is done either by swim up technique or density gradient centrifugation. This density gradient centrifugation is preferred to the swim up technique. This has already we have seen that in a diagnosis and evaluation and treatment of male factor infertility. Sperm incubation is done for 0.5 to 4 hours for capacitation. Each oocyte is incubated with 50 to 100,000 motile sperms for 12 to 18 hours. Fertilization rate is around 50 to 70% with this conventional method. Zygote is inspected under the microscope to rule out polyploidy. Polyploidy can occur in 5 to 10% of the cases, and it might be missed later on. Even some test for the pre-implantation genetic testing also might miss this polyploidy, and that is why it is better to inspect at this stage only the zygote to rule out polyploidy. Embryo culture is where the embryo is kept in the culture medium and it is used for the growth of fertilized ovum. Now, two types of embryos are transferred in IVF. One is called as cleavage stage embryo, where there is a morula which is present. 8 to 32 cells are present in the morula. Whereas second is the blastosis. Blastosis is where there is a surrounding trophoblast with the inner cell mass from which the embryo develops, and there is a blasto uh, cavity which is called as blastomere, and this is the zona pellucida which is surrounding the morula as well as blastosis. Now whenever we want to transfer blastosis, embryo culture is required for a longer duration. It is called as extended embryo culture. It is required for blastosis transfer. Implantation rate is better with blastocyst transfer as compared to this cleavage stage embryo transfer, but risk of loss of some early embryos and cancellation of transfer is present whenever we go for blastocyst transfer. So either we can go for morula transfer or blastocyst. Success implantation rate is though better with blastocyst. Some in some women we may have to do the go for cancellation of the transfer if we only wait for development of blastocyst. There can be loss of some of the early embryos or morula stage embryos might not develop into the blastocyst at all, and that is why cancellation might be required in some patients. Assisted hatching is, what is the meaning of the word hatching is, it is separation of the embryo from zona pellucida, and normally the zona dissolves. This helps in implantation so that the trophoblast now can erode the endometrium. Assisted hatching is artificially thinning or opening the zona pellucida. It is not recommended as a routine as it might damage the embryo. It is indicated in transfer of thawed blastocyst, which improves the implantation rate. So this is how zona pellucida is present. This is the trophoblast and this is the inner cell mass from which embryo develops, and hatching is where the opening or thinning of the zona pellucida is done artificially. In a normally, what is happening is this zona pellucida is getting dissolved in the uterine cavity because of certain secretions of the uterine in the inside the uterine cavity. And artificial hatching is where the with the help of a laser, this assisted hatching is done. Now coming to pre-implantation genetic testing, it is the testing of removed nuclei from polar bodies or the testing of the cells from embryo. So it is of two types, where whenever we go for only monogenic disorder, specific disorder, it is called as pre-implantation genetic testing monogenic disorder for M, PGT M. Previously it was called as pre-implantation genetic diagnosis, but now the terminology which is used is PGTM, where for specific monogenic disorder we are testing. This is testing for a specific genetic disorder being carried by one or both partners. On the other hand, if we see for the in general for aneuploidy, then that is called as PGT-A. It was previously called as pre-implantation genetic screening, where the testing is done when both the parents are genetically normal. Various techniques for PGT are: fish is fluorescent in his situ hybridization. It is abundant now because better techniques are available. It tests only small sections of maximum 12 chromosomes. So it cannot test all the chromosomes. Array comparative genomic hybridization, ACGH, is it can detect aneuploidy and unbalanced translocation. It cannot detect balanced translocation, inversion, and polyploidy. Single nucleotide polymorphism array, SNP. It is useful for both PGT-M and A and for detection of unbalanced translocation. Quantitative PCR helps mainly for the specific monogenic disorder detection. Next generation sequencing is the most preferred technique at present because it can detect for whole chromosome aneuploidy, segmental chromosome imbalances, as well as single gene diseases. So the students should remember the names of these various techniques and remember that fish is being replaced gradually wherever facilities are available by the better techniques. Testing of polar body nucleus is now replaced by embryo biopsy as the reliability is better with embryo biopsy. 1 to 2 nucleated cells are removed on day 3 of fertilization. It can sometimes reduce the implantation rate, this technique itself. Blastocyst biopsy is preferred. It is also called as trophectoderm biopsy, where 5 to 10 cells are removed from around 200 cells of blastocyst. Now, last part is embryo transfer. No anesthesia is required, no prophylactic antibiotics are required. It is better if it is done under abdominal ultrasonography guidance rather than doing it as a blind procedure. Trial transfers help. That means before we go for the transfer, before we initiate IVF cycle, trial transfer is tried mainly to rule out cervical stenosis. Soft catheters are used as if firm or hard catheters are used that can damage the endometrium and it reduces the implantation rate and pregnancy rate. Single embryo transfer is indicated in younger women with an age less than 35 years. Elderly women, 2 blastocysts or 3 cleavage stage transfer is indicated whenever age is greater than 40 years. Thank you so much. Mainly, I have prepared this topic from Spirops Gynecological Endocrinology. A gentle reminder, this presentation is for specialty students and consultants of Obst and Gynecology. It is not meant for IVF specialists. Thank you once again.